for the introduction. I'd like to thank the organizing committee also for allowing us to present the data of this phase 1 study on the combination of Olaratumab with Doxorubicin and Ifosfamide. These are my conflicts of interest. In the context of this study, I've acted as a consultant for Lilly for the development of Olaratumab. As most of you know, Olaratumab is a fully human monoclonal IgG1 antibody against the platelet-derived growth factor receptor alpha. In a randomized phase 2 trial, it has resulted in an improvement of the overall survival when given in combination with Doxorubicin over Doxorubicin alone, which then has led to an accelerated conditional approval for that particular combination. The combination of Doxorubicin and Ifosfamide is also frequently being used in patients with metastatic disease, particularly those with symptomatic disease or those who could be candidates for surgery for metastatic disease. And some in this room also use it for stage 3 disease. There has been a randomized ERTC trial comparing combination and monotherapy, and this showed that actually the combination increases the response rate and also the median progression-free survival, but this trial did not result in an overall survival benefit. It nonetheless increased, it more than tripled the frequency of febrile neutropenia. So given the fact that the combination is frequently used, the aim of this trial was to test the combination of the antibody and this combination. The primary endpoint for this trial was to determine the safety and also the recommended phase 2 dose, and secondary endpoints were anti-tumor activity, pharmacokinetic analyses, and also immunogenicity. There were 2 pre-planned cohorts. The first cohort was Olaratumab at a dose of 50 milligrams per kilogram, and cohort 2 was a loading dose cohort where in cycle 1, 20 milligrams per kilogram were used as were done in the randomized phase 3 trial. For each cohort, 15 patients are planned, and it was considered as an acceptable DLT rate when not more than 8 patients out of 15 would develop a DLT, and this was based on the observation of the combination of the Judson trial. So less than 10% increase for the historical data. And you can see in the schematic what the doses were for Doxorubicin, 75 milligrams per kilogram, and Ifosfamide, 10 grams per square meter. The DLT criteria were febrile neutropenia. It was grade 4 neutropenia for more than 7 days, grade 4 thrombocytopenia, or grade 3 with hemorrhage, or any significant or non-controllable, non-hematological toxicity of grade 3 or more. These were the key inclusion criteria, which were pretty standard. I'd like to highlight that it was a first-line study, so no prior systemic treatment was allowed for these patients. It was also patients who had received radiotherapy of the mediastinum or the pericardial area were excluded, or those who had a whole pelvis irradiation. These are the baseline characteristics. 60 patients were enrolled into the first cohort of this trial. It was between the period of October 2017 until May of this year. And you can see that the median age was 44 years, and there was quite a variety of different histologies included into this trial. There were 3 dose-limiting toxicities found in, there were 3 patients who were found to have dose-limiting toxicities. All of them were febrile neutropenia. 1 patient, in addition, developed a grade 3 stomatitis. The majority of the patients who received the triple combination were able to receive also the day 8 Olaratumab dose. Only in 1 patient, the dose the day 8 dose had to be omitted, and in one patient, a dose reduction had to be done. As we would expect in a combination with this dose-intensive chemotherapy, every patient had an AE, and the grade 3 AEs were frequent. This is the list of the most frequent adverse events. Again, the most common, like more than 25% of patients, and not as a surprise, the hematological toxicity was the most common one, and even though this is a illegitimate historical comparison, it's still compared pretty much to the Judson trial. This is the waterfall plot, which shows the tumor shrinkage of the patients. We observed 25% of objective remissions, so for patients, and there was a disease control in 69% of the patient. I'd like to highlight that there were 4 patients with subtypes that usually are considered not very chemotherapy sensitive, 2 clear cell sarcomas and also 2 MPNSTs. This shows the swimmer plot of this trial, and you can see that not all of the patients have already had the chance to receive 6 cycles of chemotherapy. All of them have passed the toxicity period of the first cycle. To date, 7 out of 8 patients who have passed that period have actually completed the 6 cycles. 4 of these patients have progressed to the Olaratumab monotherapy. 3 patients within this group have discontinued due to progressive disease. 5 patients have discontinued due to physician's decision or due to subject withdrawal. 3 patients actually have been forwarded to surgery. This is just an example of a partial response in a synovial sarcoma, presumably one that we could also observe with the Doxorubicin combination. It was unusual primary location in the prostate area with a diffuse pulmonary metastatic spread. After 6 cycles, the patient had a major clinical benefit. So I would like to conclude. Based on the first cohort, we can say that the addition of 15 milligrams per kilogram Olaratumab to Doxorubicin and Ifosfamide is safe and tolerable. And for this small cohort, it was manageable in terms of the side effect profile. 7 of 8 patients who already had the chance to complete actually completed the triple combination of 6 cycles. There were no patients that had to be discontinued for treatment due to an adverse event, and there was an acceptable dose-limiting toxicity rate as was proposed for the protocol. It was 19%. The AE profile and the DLTs were basically consistent with what is known for the Doxorubicin ifosfamide toxicity profile, and the preliminary anti-tumor activity is encouraging. It's 25% overall response rate and 69% disease control rate. So the ongoing cohort, again, looks at the loading dose of 20 milligrams per kilogram in cycle 1. Finally, I'd like to thank the patients who have participated and the families who have supported that trial.